Hello everyone. We will talk about implant prosthetic steps in an easy and enjoyable way and solve side effects in this prosthodontics on Friday. I am Jo In-ho, the MC of the program. Today, we are going to deal with the third topic of the top 5 hot issues in a series. The speaker is Professor Bae-aran, Prosthodontics, Kyunghee University Dental School. Would you briefly explain what you are going to talk about today? Today, I'm going to talk about narrow diameter implants. Recently, the implant and the dental materials have been advanced, and implants are placed in more senior patients. When we have to do bone grafting, we need to pursue the minimal invasive approach, so the demand for narrow diameter implants are increasing. I look forward to Professor Bae's presentation. If you're watching on the dental site, you can ask questions using the chatting window on the right-hand side. In real time, the answers will be provided during the Q&A session. I hope you engage in the discussion actively. Let's get started with the third topic of the hot 5 issues with Professor Bae. Hello, I am Aran Bae, Department of Prosthodontics, Kyunghee University. I'm going to talk about narrow diameter implants. To achieve long-term stability, we need to adhere to the principles of prosthodontics, and we need to be careful in selecting cases. Ortho patients like this, on the labial side, dehiscence can be a concern in a narrow bone cases. The cervical mesiodistal width looks sufficient, but at the root, due to the directional difficulties, placing an implant can be a challenge. However, 2.9 millimeter diameter implant can be used for this kind of restoration. Recently, Academy of Oral Implantology research results show to avoid bone augmentation surgery, minimally invasive implantology is being developed. Short implants less than 10 millimeters in diameter, the demand for that is increasing. The narrow diameter implants less than 3.75 millimeters in diameter used frequently in single tooth cases. One of the minimally invasive surgery, the guided implant surgery, is adopted by many dentists. According to the research result, short implants are used in 5.5% of all fixtures, and narrow diameter implants are used in 19.5%, and guided surgery is used in 10.6%. So the bone augmentation is being avoided using these procedures. If you look at here, mini implants and narrow and small diameter implants. In general, mini dental implants refers to the diameter ranging from 1.8 to 2.9 millimeters in diameter. Next, In this case, they're used for interim purposes, for temporaries, and they have the one-piece design characteristics of the mini dental implant, whereas narrow and small diameter implants, the diameter is less than 3 millimeters. In this case, it is used up to the definitive fixed prosthetics, and they are available as two-piece design, and the insertion torque for implant placement is required. That's the characteristic of the implants. Many companies manufacture narrow diameter implants. Locally, OSSTEM has the TS3 3.0 diameter implants on the market. Tightening torque for the abutments vary from fixture to fixture. It ranges from 15 to 35 Newton centimeters. Some systematic review on the success of narrow diameter dental implants, standard diameters versus narrow diameter implants. Depending on the diameters, there are different categories. Category 1 is mini implants less than 3.0 millimeter in diameter. Category 2 has 3.0 to 3.25 millimeter diameters for single tooth indications. Category 3 is defined as 3.3 to 3.5 millimeter diameters. Depending on the categories, the success rates are compared. Mini implants Category 1, non-load-bearing teeth, anterior teeth or edentulous arch. The success rates reports are not many. 3.0 to 3.25 millimeters. Category 2, most of them have two-piece design, and there are a few study reports, but no long-term data. Whereas Category 3, 3.3 to 3.5 millimeters, if you carefully select cases, stable long-term outcome can be achieved. May I ask a question? Of course, Delphi Study 2030. CAOMI, Korea Academy of Oral Maxillofacial Implantology, and European EAO conducted a survey among their members. CAOMI said that in 2030, the similar diameter implants will be used. The response was 79%. Narrow implants, 17%. Wider implants, 3%. According to EAO, similar diameters to today, 63.5%. Narrow diameters, 36.5%. And wider diameter, 0%. Therefore, narrow diameter implants is expected to increase more than twice in Europe compared to CAOMI results. What do you think? Thank you very much for the question. EAO conducted the Delphi study. What implant trend will emerge in 2030? There were many different categories, and implant diameter was one of the categories. In Europe, wide diameter is not very much requested, but the request for narrow diameter is higher. In the survey conducted by CAOMI, wider diameter implants is required more. Maybe that is because the Korean dentists are more concerned about the strength of the implant, the fracture. And also, Korean dentists are very skilled in bone grafting, so narrower diameter implants are not really demanded by Korean people. So Europeans are placing implants more conservatively, and there's a difference in the food we take. Koreans enjoy hard food, so more concerned about fracture. Do you think so? Yes, the dried squid is very tough to chew. That's correct. Thank you. Would you continue with your presentation? As I said before, narrow diameter implants indication needs to be considered in selecting the cases. When the alveolar crest is narrow or the interradicular bone is not sufficient, a narrow implant can be used. Next, if the cervical diameter is narrow where an implant needs to be placed, especially the upper lateral tooth of a young patient on the labial side, dehiscence exists. So for such cases, narrow diameters are considered as an indication. In general, when the interradicular bone is less than 6 millimeters, regular diameter of 3.75 or 4.0 millimeter diameter implants cannot be placed, so a narrow implant can be used. Where the mesiodistal bony space available is less than 5 to 6 millimeters, without ortho treatment, small diameter implants can be used. When we place an implant, the bone surrounding the implant should be at least 1 millimeter. If the width is small in a narrow reach, small diameter implants can be used. In this case, in the anterior region, due to peri-implantitis, the bone is resorbed up to the adjacent teeth. So the 4 anteriors in the mandible were extracted. 2 narrow diameter implants were placed. Due to lack of space, not all 4 anteriors could be restored, so 3 of them were placed. In 5-year follow-up, the surrounding bone and the soft tissue is very well maintained. In the case where the mesiodistal space is reduced, a narrow diameter implant can be placed, especially for maxillary lateral incisors and lower incisors. If the mesiodistal space is less than 4.5 millimeters, a narrow implant can be placed. For the desired emergence profile, the implant must be buried 2 to 4 millimeters more apical than the CJ of adjacent teeth. In a central incisor, this patient was undergoing ortho treatment. The central incisor was missing. 6.25 millimeters is the mesiodistal width. In this case, 4 millimeter regular diameter implant could not be placed. So even though it was a central incisor, narrow diameter implant was planned. If possible, I prefer screw-type implants. So the screw hole should be on the palatal side. The buccal bone volume is deficient quite a lot, so a lot of volume of bone grafting was done. The screw hole was to be on the palatal side when the implant was placed, but it is a little bit labially positioned. So zirconia abutment is used. Laminate type prosthesis is planned. Zirconia abutment itself is designed to look like a prepped abutment. Zirconia abutment looks like a prepared laminate. Laminate type is attached with a resin cement. Screw-type implant is what I prefer. To prevent periimplantitis, screw-type implant is known to all that it has better prognosis. Emergence angle is very important. If possible, convex or emergence angle of more than 30 degrees are known to have more periimplantitis. So the emergence profile needs to be made concave in designing them for long-term maintenance of soft tissue and the bone tissue. Screw-type zirconia is used. Titanium resin base concept is utilized for implant prosthesis. In many cases, emergence profile for tissue level implant, it is a little bit difficult to make it concave, but tissue level implant has less chances of periimplantitis according to reports. So for tissue level implant, this does not pose serious problem. Concave or flat emergence profile should be designed for prosthesis, not only for narrow diameters, whatever the diameter may be. This would give more stable long-term outcome. There are many other studies regarding emergence profile. Healing abutment, wide versus narrow. The study was done with beagle dogs. If you compare the height between the implant shoulder to bone crest, in the case of narrow diameter, histology or micro-CT showed much better outcome according to this paper. In general, recently we use this approach quite a lot. Titanium custom abutment is fabricated and the zirconia crown is cemented over it. The titanium customized abutment is fabricated and zirconia crown is cemented over it. The prognosis is very good. However, after 10 or 20 years, the retrievability is a concern. In this case, the root resorption occurred, so it had to be extracted. Customized abutment is used. Veneered zirconia crown is cemented. When the thickness of mucosa covering titanium or zirconia abutments exceeds 2 millimeters, the difference in color of soft tissues is not noticeable. However, for retrievability, titanium link abutment can be used. For zirconia crown, the screw type prosthesis can be fabricated. Titanium link can be used, and zirconia abutment or zirconia crown can be fabricated as a screw type for better retrievability. 5 implants are placed. They are from many different companies and they are of different diameters in this case. As you can see here, number 14, 24, 44, they are all customized titanium abutments are used and zirconia crowns are cemented over it. In quadrant 3, screw type zirconia crown is mounted. If you look at the bottom on the right hand side, number 35 tooth, the soft tissue doesn't show the metal inside. Very stable soft tissue outcome is observed. Recently, titanium link is used for zirconia abutment. That's what I prefer these days. You can see the soft tissue is very stable. In the long run, when it needs to be retrieved, it can be done very easily with this design. In the case of a narrow diameter implant, in this case, the bulky zirconia can be used. Using this type, it is more favorable. Zirconia should be at least 1 millimeter. So when it comes to the narrow diameter implant, more bulky zirconia can be used. Very big plus for longevity of implant. Titanium link screw type zirconia abutment is designed in CAD. Bonding can be done with self-adhesive dental cement easily. Regarding the concept of the titanium resin base, there are studies regarding the fracture strength, one-piece type, internal connection versus external connection. So those are the two groups. Among the internal connection, zirconia abutment and titanium resin base. And titanium abutment, one-piece titanium abutment group, the fracture strengths are compared in this paper. Rather than the titanium only one-piece abutments, titanium resin-based concept group shows higher fracture strength. May I ask a question? Sure. Today, the implantology history gets longer. The implant manufacturers and the dentists are keenly interested in the fracture of implants. There are complaints about the fractures. So in using the narrow diameter implants, we are very much concerned about the fractures. In order to prevent the fractures, dentists, patients, or implant manufacturers need to be careful. What are the things we need to be careful? So would you summarize what needs to be done in that respect? As I said before, The dentists need to select cases very carefully, considering the indications. Implant manufacturers should develop and heighten the strength of the implant materials so that dentists can place or use the implants without the worry about the fractures. Patients, we need to give instruction to the patients what they need to be careful about to avoid fractures. This is not a published data, but our hospital studied the survival rate of narrow diameter implants with less than 3.3 millimeters in diameter, placed between 2013 and 2017. 210 implants were placed, screw loosening 3.8%. Fixture or abutment fractures have not been reported in this 4-year study. So the success rate is 95.7% as reported. Therefore, if you can choose the case carefully, you can use them very well. That's very good performance. The prosthodontists in Kyunghee University are very well skilled when it comes to the implant prosthesis. I believe the manufacturers are strongly desiring to increase the strength to prevent the fractures. If a fracture of an implant happens, a patient strongly protests against the dentist, who in turn protests against a manufacturer. The manufacturers are careful because increasing the strength against the fracture may affect the capability of osseointegration. That is right. Professor Bae, would you continue with your interesting presentation? Indications of narrow diameter implants. You need to be able to carefully select the cases. It is indicated for single tooth restorations, central and lateral incisors in the mandible, and lateral incisors in the maxilla. And this is not indicated for bridges and others. You need to be careful in using them in such cases. When the space is less than 6 millimeters, it can be used, as I said before. For the central incisors, according to the anatomic book by Miller, the average space, mesiodistal space, is 8 to 9 millimeters. So in general, regular diameter implants can be placed, but if the space is extraordinarily narrow in the central incisor area, this can be placed. In this case, this is canine. Deciduous canine has been around for a long time, so the space is very small. In this case, even though it is a canine, a narrow diameter implant is placed. 2 years after, you can see there's no bone resorption, and the outcome is pretty good. Professor, in this case, do we need to use the group function occlusion? Yes. Lateral guidance should include the premolars. In this case, a bridge is contraindicated. Having said that, in this case, the buccolingual, the bone width is very narrow, so a bridge with 2 narrow diameter implants is used. Titanium abutments are milled. Monolithic zirconia bridge was provided in this case. 2 years later, the stable outcome is observed. narrow diameter implants used in the posterior region is reported. This paper was published in the Implant Dentistry. This is the guideline, kindly tabulated in a table, talks about NDIs in the posterior jaw, alloying titanium to zirconium provides favorable mechanical properties, showing better outcome according to the article. As you said before, the manufacturers are trying to deal with the fractures, and this is relevant to that topic. We need to consider occlusion for prosthesis. To prevent lateral force applied to the implants, the occlusal adjustment should be made, and the occlusal table should be created that way. Lastly, take-home messages. Minimally invasive dentistry is being developed quite a lot. Bone graft is a good method, but we can approach more conservatively using the narrow diameter implants. That can be a good choice. When we use it in the posterior region, as I said before, the guideline should be adhered to in the procedure to have better success rate. Fracture and other biomechanical problems, we need to be careful in selecting cases. Thank you very much for the good presentation. We have received the questions in real time, and we are going to answer some of them. Thank you very much for the good presentation. Cheers, Professor Bae. Here, 신나는 주말 is the idea of the questioner. What is the most important thing when it comes to the peri-implantitis? Actually, regarding the peri-implantitis, Professor Jo Gi-sung talked about it. When we use narrow diameter implants, do we experience less peri-implantitis? What do you think? Actually, the narrow diameter implants, I've talked about it today. We don't really have a lot of narrow diameter implant cases. Regarding narrow diameter implants, I have never experienced peri-implantitis at all. So I cannot really speak for how to resolve peri-implantitis for narrow diameter implants. From the top of my head, after placing a narrow diameter implant, peri-implantitis would not really occur when the distance between the adjacent teeth is proper. We talk about 30 degrees of emergence profile, but if we have a 45 degrees emergence profile, this can occur. Maybe this question is about geometric problem of an implant, emergence profile angle relative to the adjacent tooth. So sometimes we have to remake the prosthesis. If other conditions are favorable, there's a good distance from the adjacent tooth and oral hygiene is good, peri-implantitis may not occur. If it occurs, we can follow the general principles addressing peri-implantitis. We will invite another speaker on this topic. Professor Jo Gi-sung talked about it, but we will have another talk on this. The ID Kwalija sent us a question. Is 3.0 a narrow implant? Is it? Yes. You talked about narrow to be 3.5 or less, right? Regarding the criteria, there are different guidelines and criteria depending on papers. The criteria that I mentioned was for research results. When we talk about mini implants, it usually refers to 2.9 millimeters or smaller, and they're mostly in one body. 3.5 or less is considered as narrow implants. So 3.0 can be considered as narrow implant. From the ID hot issue, many manufacturers are manufacturing narrow diameter implants as one-piece implants. What do you think about one-piece or one-body implants? Another question below. What do you think about the mini implant retained overdenture? What do you think about that? Narrow diameter implants are manufactured sometimes as one-piece implants. We don't do that in Korea, but sometimes zirconia abutments are manufactured as one piece, maybe for strength reasons. We don't have a variety of prosthetic options. It is not easy to have desired shape with the one-piece implants. So from the prosthetic perspective, that is not to be used for the definitive prosthesis. Mini implant cases are reported. If you look at the success rate according to the papers, 4 or more mini implants need to be placed in the mandible, and for maxilla, they can be used when complete denture is used. 4 or more implants can lead to success, according to my experience. And the longevity will be better if you have the complete denture in the maxilla. I agree. We had very good time discussing interesting questions. Do you have any words of encouragement to the junior dentists who are studying implantology? Professor Bae is the first female speaker we have invited to this prosthodontics on Friday. If you have any words of encouragement to the female dentists who are in the implantology, I don't know whether I'm in a position to give encouragement or advices. I am in an official position. This profession is dynamic every day, very good job. So I'm proud to be in this profession. Looking around, there are so many young dentists who are passionate in studying and in treating patients, also in various fields of activities. It's very nice to see, and I also learn a lot from the young generation. So if they study harder, they will have more interesting experiences. Professor Pat talked about selecting abutments in a very narrow, restricted spaces. Thank you very much. Now it's time to finish the prosthodontics on Friday. If you have questions not yet answered, we will provide the answers online. Next time, we are going to talk about the fourth hot issue, how to adjust the loading time in a patient with poor bone quality. Dr. Sung Moo-kyung is the speaker. He is with the Mukdong Husband and Wife Dental Office.